Hello, great world. Welcome to Community Connected Health. I am a co-host, Skip Lowe, joined by
Colton Storla.
By the way, happy birthday, buddy.
Thank you.
Yeah.
Birthday week, birthday month.
You're looking good, man. I tell you, thanks for getting me all hooked up on your vitamins and the creatine. By the way, this is not a pitch for that by any means, but I'll tell you what.
Trying to stay young, fit.
Well, we got to look the part, and we got to act the part in this business, right? And that's what we're going to be talking about today is how do we do what we do, and just really excited about today's content just because we get to share the case studies. And you might recall a couple years ago when we started jumping into all this fun, I said, Colton, where it's going to start making a difference, where we're going to cross the threshold is when employers are going to say this is working great. Obviously, that's the easy part of this, but seeing the data and looking at the other side of the coin and saying, okay, we finally have the information and to be able to demonstrate that action to prospects and say, yeah, this is the people that are doing it. So, our content today is we're going to center on 4 different employers and
Community Connected Health at Work.
Yeah, Community Connect.
That's our title. There's our title.
There it is. We're rolling with that, right? And so we selected 4 different distinct organizations that are in different spaces. Some are in healthcare, of course, which is great because when you make the doctors happy, you can make anybody happy. That's what I found in life. And then we've also got people that are in the public sector and manufacture. And so I think the biggest challenge I had in this is when I got a phone call in a frigid January day from a former client of mine, and she had taken on a role at a new, larger organization, one of the most prestigious orthopedic groups in the state of Iowa. And since we're on TV, I won't use what she said, but she just said basically her plan was and then I said, yeah, I hear that a lot. And she says, let's get the band back together. For those of you that remember the Blues Brothers, I'm just referencing that great movie. But I said, yeah, let's have a talk. What's going on? And for the next 5 minutes, she just dumped it on me. She said, the employees are very unhappy. The doctors are very frustrated. The chairman of our board, who is a board-certified surgeon, says, this is just craziness. We don't know what's going on. Again, where is all this money going on? We have huge morale hazards. We're not recruiting people. This 5-10% increase every year is just driving us crazy. And so what you got?
Yeah.
Yeah, I was just in that moment of truth, and I said, well, really trying to establish my career and just tear it all down and rebuild it and re-engineer where I'm at, because my DNA has always been there. I'm all about trying to help our communities, trying to spend our dollars locally, and then with what we're doing, keep the dollars locally. But how do you do that in healthcare? When I've been crawling through piles of data for years and years, and each and every year it just feels like I'm pulling the string out of my neck. Like, hi, how are you? How are your kids? Sorry about your increase. We'll see you in 6 months. So it's just like you're a puppet. And I had a employer say, I walked in the room for an employee meeting. He says, here comes Dr. Death. I'm like, I need a sickle and a hoodie on at this point. The Grim Reaper's here.
Sometimes we have to deliver bad news.
Yeah, we do, but it doesn't have to be consistent. And so, so we'll talk about this group in a little bit more detail. And again, what do you got? And then she mentioned this group that I'm affiliated with and certified with was just Health Rosetta. Do you know anything about them? At that point, I wasn't affiliated with them. So who did I call?
Me.
Yeah. So I'd gotten to know you over a 2-hour conversation. So thank you for your kind time, because I was just like, man, light bulbs are just getting screwed in all over the place. And I'm like, oh my gosh, where have I been? I've been hiding underneath my desk. And it was, I was able to go ahead and deploy some of what I knew at that point. And I said, well, let's take a look at, your program, and let's see if we can't just blow it up. And, they have a traditional, won't name their name, but
carrier model.
And I said, you're going to have a TPA, you're going to have a insurance contract, and you're going to have a network, and then you're going to have a pharmacy benefit manager. But we're going to pick and choose the people that we think are going to do the best job for you under whole new principles. And we're going to grade your plan for transparency. Are you getting the reporting data? Check mark, no. Are you getting access to your contracts with your vendors? Check mark, no. Are you getting access to what you're paying your broker? No. And so I said, well, there might be some misalignment here that we have to spend some time on, which I'm glad to do for you. But as I like to say, easy's not in the Bible and easy's not in healthcare. And so she challenged me. I said, yeah, let's take a look at this. And so after several months, we came back with a plan and worked with an independent TPA that was able to adjudicate claims. We gave them a network in which they could go anywhere they wanted to. But we had an incentive network that we put on the front of the plan, and we were able to get them $0 for certain services, including direct primary care, which we had our great friend, Dr. John Vanderveer, on the last call. And so he has a subscription model. We got some breaks on the underwriting on it. And then you and I spent some time dealing with the pharmacy. I'm still having PTSD on that. And because that was at that point in my career, I really felt like I needed to find out what was going on with all this pharmacy. And that's a teaser alert for the next episode, because we're going to have a really good talk on that. And so we built our contract from the ground up. And then we also had the ability to put some vendors in place that worked in tandem with our pharmacy benefit manager that would interact with the members when they had a higher cost medication. So drugs typically over $300. Your 98% of your medications are going to be sourced through your local pharmacy, because that's the fear you always run into in these things. And we had international medications. We had about 300 different ones that we could choose from. And so we had nurse navigators that would work with them, and care navigators that said, hey, we've got some options for you for $0. And then, of course, we had some surgical services as well. So I don't want to get too far ahead in down into the stream here, but the one thing that I learned through the whole process was, it's not just about price. There's the fear of the change. I'm a messenger of change. I hate change. I don't know about you, and you know me with technology. I'm working at it. So you're my conduit to popular culture, as I like to call you, but. There's the things that had to be consistent through this process is we're going to have a pay-as-we-pay insurance contract, so it lines up with the TPA. We're going to match your benefits, so if you do want to go to that PPO doctor, you can go to any doctor in Iowa, or you can go to Mayo Clinic, you can go to Baylor University, all the centers of excellence. You've got kiddos traveling outside the state of Iowa for school, or living outside the state of Iowa for school. So we just, we checked all the yeses against the no's that she was dealing with, and then, of course, there's the other thing is there's been some pretty bad operators in the retail health insurance space. And so they're like, oh, man, we did this a couple of years ago. Have you ever heard that one?
Oh, yeah.
Yeah. And so I said, this is going to be fine. You've given us a huge amount of trust here. And rely on the relationship that we had for a number of years with your former employer. Know that I have the same intensity and the same integrity, and that I'm going to work tirelessly, because these custom health plans, as you well know, Colton, they can be a handful sometimes, because now you've got a bunch of vendors that you're hoping they all get along nicely in the sandbox, but they're also communicating. Oh, did I mention we did this all during the height of COVID?
Yeah. Well, I think the unique situation in this one was, with it being, a healthcare organization. And obviously we can pull a lot more levers within their plan, because they actually deliver care. And, there's no reason why we need to have additional middlemen sitting in between these transactions that are happening, especially for the folks that were receiving care at this orthopedic group. So being able to get, as, creative as we can for MRIs, new knees, new hips, things of that nature. So they're not simply taking money out of one pocket and then putting it into the other, and everybody's taking their piece of the pie along the way. So definitely a unique animal when it comes to working with groups in the healthcare space.
Yeah, well, and it was a big group, and so they were right down the road from a brand new DPC and wanted to know, how is this all going to work? Has it worked good? We're like, yeah, it's going to work great. And it's not getting ahead of yourself, not trying to get the sale and go down the road, and hopefully everything will work its way out in the end. There was a lot of time and effort that was put into this relationship with this direct primary care because, an orthopedic group, they're a different animal than primary care. And so I'm not talking about egos or anything of that nature. There's just expertise and the values of that. And so we wanted to break down those barriers. And, right after we implemented this, it was almost immediate. I'm going to say within 30 days that a number of employees and members of the plan were saying, this is fantastic. We love going to direct primary care because they paid zero.
Yep.
That was the least of their worries. They said, this is the best care we've ever had. They went there with thinking, hey, this is a pocketbook decision.
Yeah, and as you say, it's not all about, the cost of the plan. I mean, we sometimes lead with cost too much because if we're sacrificing care, then it's like, well, what is it? Cost is out the window. So yeah, we were able to lower their premiums drastically by moving to this sort of model, but, improving care, creating that connectivity between that group and the direct primary care group to get, their employees access to primary care, which was definitely needed. So as you call it, friends of the program, these two healthcare organizations already knew of each other. And it's like, well, how can we establish a relationship between the two of you? And again, cut out as many middlemen as possible that are ultimately driving up costs, creating a barrier to care. And, alternatively, now all these employees get to, and their family members get access to direct primary care. And their plans are now much more affordable. And we've just continued to, sharpen our sword per se since then, because there were some vendors that weren't, working very well, weren't willing to do what we were trying to accomplish. So, being in a custom health plan arrangement, okay, well, let's boot this vendor out and let's put a new vendor in that would be able to deliver on what they're trying to accomplish. So we definitely learned some things along the way.
Yeah, we certainly did. And that's just part of what you have to do. And last night, actually, I had dinner over in Des Moines with this group. So great timing to have this today. Glad I didn't oversleep for this. But the chairman that I mentioned earlier in the discussion said, it just comes down to we have a moral imperative as physicians and as care providers. Yeah. And we had the DPC at the table as well. And it's not every day an insurance broker is sitting at the table with physicians and specialists and the CEOs of these organizations, and we're all in the same boat. But you bring up a really good point. It's like, if you look back in this country and its history, and I'm a fan of the Wild West and the pioneer days. It's like we're the pioneers. We're going through all these rapids and forests, and we're getting stung by bees and porcupines, and we're getting chased by bears. We're taking arrows a lot, and we're in the trenches on this. This is the Alamo. And because there's a lot of people that are trying to break down the gates and reverse engineer what we're doing, or tell the status quo carriers that this is going to be bad for you. And again, I'm just so tired of the finger pointing of all this. Yep. And Chris Deacon's book just came out. She's awesome. Hopefully we'll have her on the show.
Yes, we will.
And she was in the state attorney general's office, and she said it. No, I'm sick of all the finger pointing. Because it's almost like in a political discussion where you've got opposite sides of the political thought process, and they eventually get to a point where they don't have the ability to debate the merits of their position. They say, well, all politicians are crooked. Oh, yeah, great. Let's go ahead and have a beer or whatever. It's kind of like that in healthcare. It's like, well, they're the bad players. They're the bad players. It's the big brand insurance companies. It's the PBMs. And you got to reset the entire narrative, because you're going to go into these meetings and you say, well, who's your insurance company? And they'll say, one of the brands. Yeah. That's what it is now, but what's it going to be in January or in July?
Yeah.
And they're like, someone might be good enough to get the network, right? That we're using a PPO network, but no one's like, I don't know. I'm like, you are. And you are, Logan. I'm looking at you, pal. I know you're good. Yeah, you're the insurance company too, because you're going to be in a self-funded health insurance plan, and so this finger pointing has got to start with a mirror.
Yeah.
You're going to have to take better care of yourself, and we're going to get you to zero because we have some great vendors on that. But it is a moral imperative, and that's the ride we're on, and we're the pioneers on this, and we're going to run into some rough motor scooters along the way that are going to try to take us down.
There's enough people fighting against what's right in healthcare and insurance, but I really liked what you had to say about sitting at the same table as these healthcare providers or organizations, literally and figuratively. Because if you have a broker or an advisor, whatever you want to call us, meeting with you every year with your renewal, and all they're doing is quoting alternative carrier options and trying to decide what's the least bad option for you, and not trying to interject. How are we going to solve this thing? It's not going to be more insurance.
Yeah.
It's removing the middlemen, removing insurance, and trying to create these direct relationships. Because like you said, the doctors are fed up, employers are fed up. It's how can we bring all these people to the table with what we know about healthcare, what they know about healthcare, what we know about insurance, what they know about insurance, and just make it, a nice functioning, cohesive, arrangement. Because in any given community, there's businesses, there's healthcare, there's employees, there's employers. How can we, connect all the dots there and remove all the bad players as much as possible?
Yeah, well, you make it sound so easy. It's too good to be true, Colton.
Yeah.
I mean, do we hear that or do we not hear that?
Oh, yeah.
We hear that all the time.
Well, and that's why we're doing these case studies, because, there's employers that have done this. And, we're going on 2, 3, 4 years with some of these companies that have said enough is enough. Let's do things differently. And very grateful to have those clients that put their trust in us to be able to think outside the box. Trial and error, because it's not all sunshine and rainbows. We know that. There are issues that do come up, but we're able to solve them, fairly quickly to make sure that, employees aren't, having that rub that, they're experiencing with, the traditional model.
Yeah. And on that note, the question I got last night is like, what's the holdup? Why, what's the barriers of all this? And so we've kind of already been describing that. And what's up with the brokers out there? And I had an epiphany, and I said, you can't be afraid of the math.
Yeah.
And I think that a lot of the brokers, there's a lot of great ones out there, but I just think, a lot of brokers and I were a little older, and, again, no one likes to change, and it's scary and all that stuff. But I think one of the biggest obstacles of it is they see it as being, a lot of extra work, and they really actually are going to have to dive in and see where the money's going. Whereas they've been conditioned, brainwashed.
Yeah.
Well,
we were those brokers at one point
Yeah.
where we weren't asking
Guilty.
the right questions, and we were just,
Yeah.
Again, that string in our neck. But you just have that moral dilemma that you're like, there's got to be a better way. And you either take the time to learn, or you just continue down the path.
Yeah, put up with the abuse, right?
Yeah.
And I'll also say blind obedience to intimidation, because there's that too. So here's that Alamo analogy again. It's like we're getting in, we're surrounded. And there's brokers that don't like what we're doing. There's carriers that really don't like what we're doing. There's PBMs, you name it. And so they're just lashing out with skepticism.
Because we're taking money out of their pockets.
Yeah. What's the 3 things you don't do? You don't mess with a man's wife, his wallet, or his kids. and when you're basically doing all 3 things when you switch carriers with some of these people. And it's not, we're not going out there being reckless on this. We're putting the work in there, and you just have to have situational chops if you're going to do this. And you can't be afraid of the math, and you're going to have to get back into the math of all this, and then you're going to have the tough questions. And so, I credit you on that, because, I'll breeze through an email You're like, what about this? Thanks for slowing me
It's
down.
all in the details. Well, maybe we move on to the next one.
Great.
Also an organization that works in healthcare, but instead of them being an orthopedic practice, it's a hospital system. That, again, they were with one of the big carriers. They were already self-funded, but continuing to see their costs increase. The new CEO, she knew you from a previous life and what you were doing at her former hospital. I think what was different in this situation, she remembered you from that situation, and now we're years ahead, and you're much smarter now and looking at other options and kind of embracing some of these community-owned health plan mindsets and Health Rosetta principles. But yeah, this was kind of another fun one to bring this into fruition. If you want to kind of speak to that a little bit more.
Yeah. You learn so much every day in this business. It scares you. And just working on their finances, not being afraid of the math and asking some of the tough questions. And, how does your charge master work? And how is your relationship with your the PPOs? Because by moving from one encapsulated carrier administrator mentality, it's like, well, I can't unplug this part and plug it in. So we, again, wanted to have access to providers was number one.
Where with this one, again, they were working with a big carrier, and of course they wanted to capitalize on their employees and their families using this hospital as much as possible. And I think they were just writing off some of the claims. So again, left pocket, right pocket. This carrier didn't allow them to set their own fee schedule. The carrier was taking their, piece of the pie along the way. They had their own internal pharmacy. However, they were working with one of the big three PBMs. So just trying to talk them through, as we say in this business, crawl, walk, run. Do you want to rip off the Band-Aid and go all in on some of these strategies, or just start to chip away at maybe the pharmacy first, and then maybe the TPA, looking at outside stop loss, so on and so forth. The fun part for us was that, she was ready to rip off the Band-Aid and go all in. So
I want to run. That's what she said.
Yep,
said,
independent TPA. We worked with a regional network, wrapped it with a PPO network. So to your point, making sure employees have access not only to internal services at their organization, but externally with other providers. And then having a PBM at the table that was willing to work in tandem with their internal pharmacy. So that's all proven to, work.
Yeah, well, and I think the other thing too is as we've gone down the road, they've been able to see the numbers and kind of analyze what's going on. And so now we're taking a sprint. We're going to add sprint to the crawl, walk, run, sprint. And so now they want to sprint to, let's take our domestic claims out of the stop loss, because that's a question I had, because I am going to market. And when the red flag is when the stop loss carrier says, can we have a report showing you the amount of claims that are going to the hospital? Because their fear at the stop loss carrier is well, are they there to make money on their own health plan? And I just hate that question. And so we're like, well, guess what we're going to do is we're going to show you an option with your employees under stop loss at your group, your domestic claims. And we're going to show you an option where we're going to carve the stop loss out for the claims that happened in the hospital, because it's a critical access hospital. So they're not doing burns, and they're not, they're not doing joint replacement. They're not doing acute care when it comes to the high cost dollars. And so they're like, yeah, we're never hitting our stop loss here, and we can protect those people for those catastrophic events outside their four walls. So getting a TPA to understand was really critical, because we're like, okay, here's all the claims or all the services that happen within the four walls. And the reward of the employees is they're going to pay a lower deductible. If they decide to have care outside the four walls, then they have a higher deductible. Getting it, the PBM was essential because the hospital had its own internal pharmacy. And getting, the pharmacists of our PBM to get along with the pharmacists internally and who was right. And that was educational, because I didn't realize that some of these critical access hospitals have access to a very special GPO, group purchasing option.
Yep.
So no harm, no foul, because we're charging a transparent administrative fee. There isn't any spread pricing in the pharmacy, so we got through that. So,
but at the same time, she's now pushing back on us.
Yeah,
a little more.
Yeah,
to sharpen our sword. And seeing, how can we capitalize on our costs internally as much as possible. So, we're now going to have a conversation with another, potential partner that can help them, with their GPO pricing on their drugs. So see if we can find some savings there so they can actually procure the medications, through maybe another GPO at much less, cost there. And then again, trying to steer as many of their employees to their internal pharmacy as possible.
Yeah. Yeah. And then, the other radical part of this year is to say, they said, our TPA has the ability for people for services outside their four walls to have a $0 deductible out of pocket. And she's just pulling her hair out going, well, this doesn't make sense. If we have a surgical service here in our hospital, it's not the same one outside the four walls. Again, it's more acute care. Mm-hmm. We're charging people money for that, deductibles and out of pockets. Why can't we just do zero for people that's, I go, great. And that's exactly what we're going to look at. And then now we don't have the liability on the stop loss. So they're going to get significant discounts. And furthermore, we're going to go ahead and revise and amend their PPO contract so that it's not, they're not going to profit from, they don't want to profit from their own health insurance plan. And I will credit the CFO. He came out of Texas, one of the nicest guys I've ever met. And he's like, here's what I think we should do. And I'm like, oh my gosh, we just haven't run into this, right? Yeah. So it's exciting to see this. And then, peeling back the layers of the onion here. I'm excited about an upcoming conversation, as you just mentioned, with some folks like, we can do that. And we can do it really well. In fact, we're launching, 5 new hospitals January 1. Yep. So again, having the situational chops is key. So that one was a tough one, just because, again, you got to make these doctors in these hospital facilities, because they're the experts. And so it puts us further down the food chain of totem pole of us being the experts of healthcare, right? So if you can make those people happy, and that's the model before I met you, that was I, but now we're a force du jour here. So we're going out, and if we can master and make the medical providers, hospitals, if we can make them happy and build them a plan like this, man, we're unstoppable. I mean, there's no bragging rights here. I'm just telling you, this is where it's at, and because now you can take that model, which is a good segue to our next discussion.
I think we're
coming around, buddy.
Here.
Yeah.
It's phase 2.
Yeah.
What's phase 2? Take it to the community.
Oh, yeah.
Once we've now proven to, XYZ hospital facility that, hey, this is what you're capable of, how can we now take that to the city, take that to the county, take that to other, manufacturers, other employers, that can piggyback off of what they're also trying to do, and moving to an independent TPA, finding that right pharmacy partner, creating these direct pay services at the hospital facility that's right in their community that their employees are already going to.
Build a menu.
Create your own fee schedule. That, again, you've got the employer at the table, you got the healthcare providers at the table, the facilities, everybody. And then, of course, us, trying to, work as the guide to say, yes, you can do this, you can't do this, and, taking that to community, and hence, why it's called community connected health.
Right, because what's part of our DNA and the mission here, if it's not everything, and that is that we're going to figure out a way that you're going to pay less for your health care, your employees are going to pay less for their health care. So we're not just fighting this ugly battle, because inflation is never going to outpace healthcare cost inflation, and so we're just chasing our tail. And so we've seen the dismantling of our small towns, and we weren't trying to keep these young kids that were sending off to shiny colleges never to return. Let's get some economic opportunity. And you've got people say, "Oh, it's over; it's never going to come back." I beg to differ. I think that when you get momentum on things, it's amazing how things can change, right?
Yeah.
There's just moments in time that you're like, man, everything changed. And this is just not Colt and Skip doing this. This is happening. Thousands of brokers, thousands of employers, thousands of hospital systems, independent-minded providers.
I don't know about thousands of brokers, but
Yeah.
there's a few.
Did I say thousands?
Yes.
Okay, all right. Yeah, but there's we'll just say hundreds. Okay,
There we go.
We'll go with that.
We know a few.
Yeah, but if someone owns a Dunkin' Donuts, they're not going to go to Casey's General Store to buy a donut.
Yep.
Can we agree on that? Mm-hmm. So if you're going to do something at your hospital, in your local clinic, whatever, you got to eat your own home cooking. And you've got to be able to put a menu together to say, hey, we're not going to do everything. Because if they say, hey, you can have babies here for $0, that might overwhelm the OBGYN department, right? So it's got to be tactical. What are some things that we can do? We might be able to do a tweak on a knee or whatever that is. Find your best and be better, right?
There you go.
And
that's a hell of a line.
Yeah, you like that? That's another one. All right. So find your best, be better, and we're going to put a menu together and say, hey, look, you can go anywhere you want to go, but if you go here for these services, you're going to pay $0. And that's
Incentive-based plans.
high quality outcomes.
Employees don't like to be told what to do, but if we can give them options that they've never had before, because all they know is, hey, I've got this little ID card in my pocket and it's an unlimited credit card. I just present it.
Yep.
And healthcare happens,
Yep.
and then I figure out what the bill is going to be on the, the back end. I don't know cost, I don't know quality.
Yep.
So let's, do the heavy lifting for them, empower the employees with options and, quality scores and lower cost options, and, educate them and build those incentives to say, hey, you can do this or you can do this.
Yep.
Choice is yours.
Yeah. Well, remember $0, right? We love to throw that line out too. Case study on this one. We'll call it a baby case study, is I think they said, yeah, we believe in you guys. Let's go for it. Here's the keys to our everything. We're like, okay. And we had a member that was getting a surgery that they didn't perform. And so we were taking a phone call. I think we were on our way to Minneapolis. And, we were putting out all kinds of calls to people. And we called one of the specialists that performs this surgery, and we said, hey, we'd like to talk to your CFO, and who do we get in touch with to try to negotiate this? And so we ended up finding, actually, there's a network that's part of our bundles, and it was at the exact provider that this individual was going to. And so I think in one of the highlights is that, this is the example where the individual did not have to pay $3,000 for their surgery, and we saved the facility. This group we're talking about, $39,000. That's a job, right? And so we have these case studies, and we've seen it on the prescription. That's kind of the easy one to really track down. But when we have people that were saying, here's where the nurse navigator reached out to so and so, and they did get their MRI, and this is just in the advancement of the technology. I don't want to get us off the beaten path, but now we're doing digital credit cards for people. Once we've had that discussion with them, say, does this make sense to you? And part of that is the medical tourism. Like, we're going to pay for your gas in your hotel while we're at it, and you're still going to pay way, way, way less than you would have you had it done in your traditional plan. So that's just some powerful stuff, because they're seeing that now. Is that, oh my gosh, $500,000 savings in prescription drugs in 1 year. How many jobs is that? Mm-hmm. What can you do with $500,000? Maybe research and development. You can build on your facility. You can.
Yeah. Well, a lot of people like to think about their healthcare costs 12 months at a time too. So, compound, over 10, 20 years, we're talking millions of dollars.
That's a great point. And that's why we're not going in with 1 year Charlies.
Yeah.
We're going with a 10-year business plan. And that's where it's got to shift.
Yeah. Well, we can move on to the next one here. Ag manufacturer. This was kind of a fun story. You want to maybe start from the beginning, just making a cold call.
4:30 in the afternoon on a Friday. I'm with a fellow salesperson. I am 3.5 hours from my front door. I'm haggard, tired, hungry, scared. I want to go home. I want to go home. Maybe have a gin and tonic, just for the record. And he said, well, we're here, we might as well work.
Yep.
I'm like, what, you young guy.
One more call.
Yeah.
One more call.
I'm all suited up. It's my deal, my shtick. And I'm like, all right. we'll go in, but it's not going to be there. It's 4:30 on a Friday. 4:30 on a Friday, folks. Go in there, and of course, all the doors are locked. Besides the, they got you in the cage there, the fishbowl, and so I'm calling the numbers. They're not there. They're not there, and finally get to the CFO.
Out of all people.
And said, hey, I won't name his name. I said, I'm Skip Lowe with North Risk Partners up in your area. Just wanted to introduce myself very quickly. I know it's Friday on a 4:30. I'll be right up.
All right.
I was expecting, I'll call, call me next week. Leave your card, And sure enough, I have this fellow salesperson. He's in the commercial line, so he's staying out of the dark side of healthcare and health insurance. And so the salesperson said, "Hey, great to meet you. Thank you for your time." I mean, I'm in my late 50s. The kid I'm with, I got to say it. I don't call you a kid anymore, by the way. You can thank me later. But I think he's 23 years old. He said, "Yeah, just out of curiosity, what's your biggest challenge right now as a business?" And he says, "My health insurance."
Licking your chops at that point.
Oh yeah.
Well,
yeah.
Funny you say that.
Well, glad to meet you. Yes. So. So I went in one of my moments, and so I mentioned what we're doing. I do have a much shorter version of explaining what we do. And he said, "This sounds great. Why don't we go ahead and connect?" And off we went. Yeah. And so this small ag manufacturer struggling, incredible story about how this was put together out of a guy's garage, 97 years ago, and corn grinders, and they do other equipment, and they're struggling like all other ag manufacturers. And he said, healthcare is his number one concern. I'm like, okay, well, let's put this together. So then
we had a meeting with them.
Yeah, we had a meeting. And then we found out that there's a small little.
Yeah, we talked about direct primary care, I believe. And I think, the HR person and the CFO were like, well, this clinic up in, XYZ, Minnesota, is that what they do? It's like, no, not that we know of.
Yeah.
We've heard of them, but maybe we can connect with them. And sure enough.
Yeah, reached out. And their story was like all other DPC founders. And they said, we were burned out. They wanted us to see 5,000 patients a year. It was fee for service. And there's deep anguish. And so that's the cool thing about DPC is just this resonating story that is consistent. So we said, well, this is what we're thinking about. And would you be interested? We got them connected to our TPA partner. Like, yeah, we can go ahead and do it. We came up with a fee schedule and built the plan.
If I remember correctly, too, in this conversation, they were obviously complaining about increased costs with their carrier year over year, just like everybody else.
Yeah.
But they were also complaining that, things weren't being processed correctly.
Yeah.
When their employees were actually seeking care. And I think there was something about like labs were being billed at their deductible and just issue after issue. And they were in rural Iowa.
Yeah.
So access to care was obviously, top of mind for them because, they had employees in the middle of nowhere.
Yeah.
So being able to, kind of, again, connect this, direct relationship with this clinic and say, hey, how about all of these employees and their family members go see you? And we'll create a membership, and it's going to be no cost to the members that seek services.
Yeah.
And they're like, no insurance, no billing, no anything. Nope, it's just a monthly membership fee.
Yep.
You take care of this population, which is not outside the box because, I think employers have done these on-site or near-site clinics for years now, the bigger organizations at least. But, this model is now being scaled down to smaller employers, the DPC model per se. So being able to, A, establish that relationship, but then B, we were tasked to build a plan that supported that relationship.
Right.
So again, same song and dance, independent TPA, we worked with a regional network, wrapped it with, PPO network, make sure people had access. Because let's face it, not everybody's going to want to go to this direct primary care doctor. Mm-hmm. However, I think we're sitting at almost 50% participation, which is great because they do deliver top-notch care. It's timely, it's quick, it's everything that they want. Independent PBM, nurse navigation.
Yes.
So we've just enhanced their plan. And again, savings isn't everything, but I think they almost saved upwards of $100,000 just in the first year.
You're correct. And the other thing is what was on this DPC relation, because this was really, this was scratch built program. We knew all the partners that we could put in play. That was the key foundation, was to get in the DPC, and they were very skeptical of us. Of course, they're like, "Well, I don't know.
What are you trying to sell me?"
Yeah, right. And that's the thing. It's like, we're trying to do good things here to help you, and this is for the greater good. And so, if other brokers come in and tag you as a DPC in the area, then you're part of their product offering. But after 6 months, they called us up and said, "We want more business."
Yep.
They got it. Right. They're like, "Oh, the opportunity cost of us of not having to be on the phone and fighting with the insurance companies, this is great." And I was like, "Yeah, we're here to restore your community and your vacations."
Yeah.
Right. And so they're begging us for more business. They're saying, feed us more. And so, it's blossoming. We're building the momentum up there.
Which we did a little interview with the local paper.
Yeah.
Right in their little office.
Yeah.
And I think once that was launched, they started to get some phone calls from other employers like, "Hey, what is this that you're doing?
Yep.
And how can we work with you guys?"
Yep.
Which is great.
Yep. School district, couple local manufacturers, and another ag organization. So, we'll see where this goes, but it's really exciting. So we call that story a little clinic on the prairie.
Yeah.
Right. So a great one. So we've gone through the healthcare side. We got a manufacturer. I think it's also important too, before I forget, people are thinking, well, I have to have 500 employees. It's like, no, we've got this thing built. We can scale it down to 10 employees on your health plan. So all these solutions are available now. Tom Emmerich, the great Tom Emmerich, right, from Caterpillar and Walmart, he's the one that kind of helped engineer this idea. But now we are scaling this to smaller employers, and that's the big difference maker, because you're not going to have 500 life employees in towns with 10,000. They just don't exist, or they're nationally affiliated. Last thing I'll say about DPC in the small community, like we're doing with other, is we're finding dance partners, as you'd say, right? Mm-hmm. So we have built, not we built, but we have engaged with national aggregators. Two great platforms. So if you've got employers say, well, we've got employees in North Carolina, and we've got people in Eastern Iowa, we have them in Wisconsin. Mm-hmm. We're like, great, we'll go ahead and do a search, and we'll find you a DPC in your area so that you can have those $0 options. And so that's the other thing that's been really neat about this, because now we're making those connections so that other employers in the area, again, the greater good, right?
Yep.
Yeah. So that.
Yeah. That's a fun little case study.
Yep. One of my favorites.
Last but not least, county government. This was another fun one.
Yep.
Because we connected with a local DPC clinic. They connected with us and heard about what we were doing. And I think at that point, they only had like 700 members, and they were just off the street. People that wanted to be there, they were paying their own membership fee. This clinic administrator, he was wanting to grow and, increase membership, partner with employers. He talked to this county and was like, hey, the county's interested. Let's bring, these folks to the table that understand the insurance side of it. Again, a situation where, they're nestled in rural, Minnesota, and access to care wasn't the greatest. Mm-hmm. And, I was already working with this gentleman with some smaller employers. And as I was meeting with employees, it was kind of eye-opening for me, because they're in Mayo land, and employees were driving either 45 minutes north or 45 minutes south just to avoid going to Mayo Clinic.
Hideous.
Because we know Mayo, they're good at very complex things, but, the day-to-day things, not so much. It's expensive. It was hard to get in. Mm-hmm. You're just in and out, and no true, care. And so what better way to, partner with this DPC clinic right in their community, so they weren't having to travel. They're getting access to timely, affordable, accessible care. And this particular county, I think, was seeing almost a $500,000 increase. They had some high-cost claimants. They were seeing, I think even the year before that, they were seeing an increase too. So, again, we got to work, And we knew that we were going to build a DPC-centric plan with this local DPC partner of ours and just say, okay, all the employees that are part of the county and their family members, now here's your DPC that's available. And of course, we always give people the option to not use the DPC.
Yeah, that's right.
I think there was still a handful of employees that wanted to go to Mayo because they did have an established relationship, which was fine. Maybe go to the DPC to get your labs done because they would be free, and then send those to your other, normal primary care physician. But again, we were at 50% participation. I think within this first, 6 or 7 months. So it always, I've been kind of asking myself, even though within these health plans, ACA mandate, preventative care is free, what percentage of people were actually going and getting their preventative exams done? Probably less than 20%. If we could get access to that data, I'd be curious to know. But because even though it's free, people I think have been burned by the systems that, hey, yeah, I'm here for my preventative exam. But then all of a sudden they get that surprise bill because they talked about, that mole I needed to get looked at or this or that.
Dealing with that exact thing right now. Yesterday, they're like, hey, I just went in for my checkup and they had a code on there for a mental health check-in. I'm like, so they're having, the surprise bill. Yeah, well, and I think it's great to focus on the zero side of things, but I think it's also really important to focus on the claim doesn't hit the plan.
Yeah.
And so how do you measure the success of the ROI on a DPC? It's like, well, actually we find out we have DPCs that are open 24 hours, so this is not probably fair for other DPCs that are working normal business hours, but the amount of people that are using the services for urgent care and the pink eyes and sutures and I had a PT specialist that he cut his hand and I said, oh geez, how much did that cost you? And he said, well, I did it myself because I have a $5,000 deductible. It's like, the infection. But that's the other side of it. It's like, yeah, the zero sounds good, but you think about a DPC, if it's structured as a subscription fee, you can go there once or 1,000 times. I mean, they'll handle the frequent flyers.
Price is the price.
Price is the price. And so, but the other side of it is the claim's not hitting the plan. And so you can see and measure the benefits and people are getting better. And they are saying, as you'd say, turn back the hands of time. It's like the way medicine used to be, the way it's supposed to be. The doctors are happier. The patients are happier. The employers are happier. I mean, it's just got win all over it, right?
Well, I mean, a little, case study because, we were looking at claims preparing for, their upcoming renewal. And I think last year, because we met with their committee to just see how the performance of their plan was going. And I think they were sitting at like $6 or $7 million in claims.
Oh.
And with all these strategies, DPC, pharmacy, nurse navigation, everything, they're sitting at like 2.5 million.
Oh, wow. No, that's...
And so actually the funny thing is this, the county asked us to, hey, can you go back to our previous carrier and see if, we're still, in the right type of plan.
Right.
Are we competitive?
Yeah.
And that carrier wouldn't even quote it. I don't know why. They were like, we want 12 months worth of data. And it's like, well, they were with you for like 20 years. So, we only have 7 or 8 months at this point. Yeah. But I'm sure that they maybe looked at the claims and are like, what in the heck happened?
Yeah.
Why? How did they, take their claims from $6 million down to, 2.5? And so, one of those ways, the pharmacy is working really well. We've got 2 employees that they're getting infusions. Previously going to Mayo, $97,000 for an infusion. And, Nurse Navigator reached out to both of them. One of them declined. One of them said, yep, I'm all in. They found an independent infusion clinic that was going to do it, I think, for like $27,000. The nurse did a little bit more research and found actually an organization that would do an in-home infusion for even less than $27,000. So
you're at $65,000 savings, which that's a job.
Yep.
And then if you can get even better than that, I mean, that's power.
Yeah.
And how much did they pay for that home infusion if they said yes?
Yeah. Employee didn't have to pay a thing.
Isn't that something?
Yep. So just creating that win-win situation that, it's great that we were able to save dollars for the health plan, but also save dollars for the employees. Because again, like you said, who's the insurance company?
Yeah.
And I think employees are quick to, complain about their health insurance premiums. And it's like, well, what are you doing, each and every day to be a better consumer of healthcare? Are you engaging with, nurse navigation? Are you looking at, alternative options and shopping around? And now to side with the employees, that information, or the everyday American, that information just isn't readily available.
No, and we're breaking
it's not
down
like
the
we can
barriers.
go to, healthcare.com and search for new knees, new hips, prescription drugs, so on and so forth. But there's one other story I wanted to tell on this group too, because they wanted us to do a health fair to kind of continue to educate the employees on, hey, utilize your direct primary care doctor. We've got these pharmacy solutions, this and that. And actually, one of the employees, she was more than happy to speak up, and she goes, "Yep, I was one of those high cost claimants. I'm on this drug that costs $450,000 a year. I got to go to Mayo, and get that injected." And so just upcharge after upcharge on these meds and the facility costs for her. So now we're having that drug sent to the DPC, and the DPC is now, administering that drug for her. And now it's, we're saving, I think, $250,000, on this claim. And
is that brown bagging, right? Am I right on that?
Yeah.
Okay.
And so now she's just thrilled. I mean, they're, from her office to, the DPC, I think it's like 4 blocks. Just go in, get out. Don't have to pay a copay, no out-of-pocket costs. It's a beautiful thing.
Yeah, it's a beautiful thing. And that's the other side of the power, is when you have testimonials. On this a little clinic on the Prairie story earlier, though, I think it's also our duty is to offer to be available for employees for a re-education, because, at renewal time, everyone's been through football and they're harvesting crops and they're dealing with family members.
Not
at
everybody
Christmas.
likes to listen to us at open enrollment.
No, and so and
educate, and re-educate.
Yeah, have a middle of the year deal. Made me think of a story last night. So, Dr. Marty McCary, who's now with the federal government, but he was a top virologist at Johns Hopkins. I'll be really quick on this. He asked a financial analyst, someone with a PhD at the university, Johns Hopkins, said, "Hey, we've got all of our medical spend for the medical college through our health insurance. I would like you to analyze this for us to find out where all the money's going." 6 months later, the guy came in just exhausted. He says, "I have no idea how this works."
I remember Dr. Marty McCary talking about that.
I mean, that's why it's just so imperative for us to get to the numbers and get to the relationships. And
transparency and control.
People are going to make money, and that's fine. And we don't have a problem with people making a living. And I don't think it's going to overall impact the quality of life or the income level of specialists when they do these cash positions and cash bundles. And so I think we're in an exciting time in this business. And I want to remind everybody, health insurance is not going away. It's $2 trillion of our economy or GDP. It's not going anywhere.
Yep.
And, people are like, well, maybe we should all have a single payer system. And that's a different discussion for a different 10 hours. But I'm just telling you,
well, it's
not going anywhere. And so we just got to make it better.
Well, as our good friend Ben John would say, we need to shift from buying health insurance to buying health care.
Yeah.
Because, these prices have just been hidden from us as consumers.
Yeah.
And, there's new hospital transparency rules out there. But we know that you go to some of these hospital websites, they bury it. It's hard to find. The files are massive. Sometimes your computer doesn't even support it to be able to open. So, we just need to make this more of a consumer-based, transaction where, consumers can be consumers.
Yeah.
Knowing the cost and quality of various services, because then that's going to create competition. Price is going to go down.
Well, you know what? I'm gonna say out of all 4 option or case studies, I have a hard time talking today, which is amazing. you're getting the Badge of Courage award for all 4. Here's why: because to have a county, a public body, to do what they did, I'm telling you what, it's like trying to find a convertible 38 Packard.
I know.
It's just, you can't.
Government entities are tough.
Collective bargaining, and they're gonna bring in union
They don't want
representatives.
to disrupt anything.
No, and there's things that go on with the big carriers and union representatives. I've seen it firsthand. I mean, I'm not making it up, folks. And
Which I applaud this HR director, because she is awesome to work with.
Yeah.
And she said, if you can deliver me, something that's going to be less expensive and the same or better, then we're going to do it.
Yeah.
But they have a whole committee that helps make these decisions, so it wasn't just her. And at the end of the day, we matched their plan designs, and now we added direct primary care. We added all these pharmacy solutions, nurse navigation. So at the end of the day, what she was selling her employees on, like, hey, we aren't taking anything away from you, and this might making this move. We're adding to your benefit program.
Yep.
And that's exactly what it is.
Yeah.
Because again, it goes back to what we say. Price is not always, the single thing that we need to look at, because if the quality is worse, access is worse, everything's worse, then it's, who cares how much we're paying? They're like, what did you get us into? I want to go back.
Everybody's frustrated with traditional healthcare. They're waiting in line for their pills or waiting in line for their care. They get sick and they say, I'm not doing it again. The doctors can't stand it. It's just a Debbie Downer. And it's like, this is just a mission-filled effort, and it plays well with the DNA here. And we got matchmakers. It's been a great show. Great to see you, bud. And
you too.
we'll be back for another exciting episode, and I'm sure we'll have some more stories and vignettes. And
I'm excited to dive into the pharmacy stuff. That's been a fun one for us. So
I've got my Chicago phone book waiting for all kinds of fun stuff there.
So tune in.
Tune in, everybody.
Next month.
Yeah, great to see everybody.
Thank you.
Take it on.